Friends, let us observe a surgery totally unedited in real time. This is a cataract with grade 3 nuclear sclerosis. Pupil size at this time is about 4.5 millimeter. And at this time, I am thinking that it may be possible to do this case without any pupil expansion device. I inject a bit of adrenaline, bit of phenytoin, but the pupil doesn't dilate. Antechamber is filled up with viscoelastic substance. This is 2% hydroxypropyl methyl cellulose. Some air bubbles has gone into the anterior chamber. Some more visco and the air bubbles are expelled out. And now is the time to do another opening, a paracentesis, 3 clock hours away from the main wound. Use the stereocoaxial illumination, take a utrata forceps and do an adequate size rhexis. The rhexis goes along the border of the pupil so that the rhexis is about 4.75 to 5 millimeter. But what I am noticing at this time is that the pupil is gradually becoming smaller. Hydrodissection is done, viscoelastic substance injected, and now at this time I am thinking to Prechop this nucleus. Yes, if you are doing Prechop for some time in smaller people, you can do it in this way. Scratch the surface of the nucleus, hook the equator and divide the nucleus into pieces. The antechamber becomes shallow. The sustainer remains in the anterior chamber, rotates the nucleus, comes to the other heminucleus. Hook this heminucleus and use the Prechopper again to divide this heminucleus. So I have got 4 pieces. I just have to go and emulsify the pieces. I don't have to go near the pupillary margin. These were the thoughts, but see what happens. As I go with the handpiece and try to pick up the pieces, the pupil becomes more small, dangerously small. At this time, the size of the pupil is about 3 millimeter. At this time, it is almost 2 millimeter. And now I change my plan. I want to use a pupil expansion device at this time. I don't want to take any more risk. I don't want to be a hero with showing my expertise. I want safety for the patient. So I fill up the anterior chamber with visco. Some amount of visco goes under the iris and use the B-HEX pupil expansion device, a beautiful pupil expander invented by my friend Dr. Subhen Bhattacharjee of Calcutta, India. It's a beautiful device. This is B-HEX 2.0. It is a little stiffer and little larger than the original B-HEX. So the B-HEX pupil expansion device is engaged. I'm using it for many years, and I can do it with just 2 ports, the main port and the left side port. I don't have to make another port to do this. You have seen how beautifully it has been applied the notches and flanges are in proper position, and now the surgery becomes a routine cataract surgery. I pick up the fragments and emulsify with adequate amount of ultrasonic energy. Friends, please use adequate amount of ultrasonic energy. I have seen my friends using low energy for hard cataracts, that doesn't save your time, that doesn't protect the corneal endothelium. You have to use ultrasound in a rhythm, give proper rest to the tip of the phaco needle, and you can have very good results and prevent wound burn. So this is the nucleus has been managed, most of the epinucleus, most of the cortex also has come out, and now a little bit of cortex is lying here and there. In small people, I feel more comfortable to use a Simcoe, go under the iris, sweep side to side, and I can catch the fibers of cortex very efficiently. In weak geniole, in genular dehiscence, Simcoe is a much safer instrument than bimanual. You don't catch the capsule suddenly and you don't cause further genular dehiscence. So don't be shy of using a simple instrument, efficient instrument, safe instrument, the Simcoe cannula. We must show respect to the man, Simcoe, who designed this instrument. Now here goes the intraocular lens as a acrylic single piece monofocal intraocular lens, and it goes in the capsular bag. Now I inject some more visco, place the lens properly, orient the haptics away from the main wound so that I can go behind the intraocular lens and clean visco. And now I take the B-HEX forceps, hold a flange which is above the iris, and mobilize the B-HEX ring and bring it out in the anterior chamber. Hold a part just in front of the main wound and gently bring it out. Friends, removal of this B-HEX ring is the simplest of all pupil expansion devices. You just gently pull it out. You don't need any injector system to bring it out. And now you just have to remove the viscoelastic substance that is in the anterior chamber and behind the intraocular lens and conclude the case. See some pigments. This happens when you use the B-HEX or B-OCTA ring. Some pigments from behind the iris get released. Please remove all the pigments and have a thorough cleaning. Though the pupil is small, go behind the intraocular lens in this way and remove all the viscoelastic substance from the space between the intraocular lens and the posterior capsule. And now I use, after cleaning about 50% or 60% of the viscoelastic substance by the Simcoe, I take the bimanual irrigation aspiration and use it for some time to remove visco efficiently. I go behind the lens, put the irrigation behind the lens and aspiration above the lens, and use irrigation aspiration for some time, and there is a thorough cleaning of the viscoelastic substance. And now you can see these pupil. It is small, round, no damage of the sphincter pupillae. This is the beauty of this device, B-HEX 2.0 or B-HEX. The beauty is there is no damage of sphincter pupillae. The cosmetic aspect of the eye is nicely maintained. And since there is no damage of the sphincter pupillae, the pupil remains small. It gives much better vision, more comfortable vision to the patient. The antechamber is nicely formed. Integrity of the wounds are checked. Few drops of moxie is applied over the cornea, and the case is concluded. Thank you very much for your attention, friends. Don't hesitate to change your plans. Change plan A to plan B if the situation demands.